I I had a funny experience with my team this morning. There was a patient with a leg wound that we'd already like talked about so many problems, and there was a lot going on, and we were also just in a rush to finish rounds, and we like hesitated for a second, and we almost didn't sort of unwrap the wound to look under the bandage. And then like we're like, we should just we need to look. So we looked, and man, was it was it a good idea to have looked just to um and it reminded me of the joke about how do you hide $100 from an internal medicine doctor? You put it under a bandage. And thankfully we found the money, but it was a close call.
Hmm.
But a good good reminder that if something was bandaged, there was something under there that needed bandaging, and you kind of need to know what that was.
There's other variations on that joke too, which we won't share for time and professionalism's sake. All right, Mark, want to kick us off? We'll kind of share thoughts, but excited to hear from others in the chat, or feel free to unmute.
Awesome. Hope everyone's doing well. So yeah, I have a fun case today. I'm sorry if there's any loud noises in the background. I am kind of in the ICU right now, but in a good spot. Very, just got like an hour of time. But
Awesome.
yeah. So we have a 33-year-old woman who's presenting with 3 months of watery diarrhea, and that is the chief complaint.
I can um I can uh start us off, Steph.
Great.
So 3 months for diarrhea is definitely kind of in a chronic problem representation. Acute diarrhea is overwhelmingly infectious in origin, whereas when you have chronic diarrhea, the sort of the mechanisms of illness that can cause that broaden substantially. And there's a couple of different ways to kind of characterize it, to think of the cause of diarrhea as inflammatory versus not. Um, to the other kind of semantic qualifiers are secretory versus sort of osmotic uh, mechanisms of essentially increased stool volume, and thus stool frequency, stool liquidness. Um, and then within those, there's sort of a broad array of infectious, inflammatory, neoplastic, or none of the above causes. So I think some of the important questions that we'll be looking for on the history to understand whether what kind of chronic diarrhea we're dealing with is just the volume and temporal pattern. So, for example, if you have in osmotic diarrhea, it's essentially some osmotically active substance that is pulling extra fluid into the lumen of the gut, right? So that could just be food in a setting of malabsorption, be that pancreatic or enteric or otherwise, or an abnormal sort of osmol-like, sorbitol, something that is being ingested that by definition isn't absorbed. I recently learned, I didn't actually look this up myself, but that apparently artificial sweeteners, if you use enough of them, that they may not be fully absorbed and they can cause osmotic diarrhea. Would love somebody to actually add what they know about that in the chat, or if you want to look it up. Anyway, so if the diarrhea is osmotic, most of the time what you're putting in your mouth is when you're awake, right? So it's less common for the osmotic mechanism to have a component of nocturnal diarrhea. By contrast, secretory diarrhea, one of the causes of which is inflammation, it's inflamed, or if there's neoplasm or a chronic infection, that process is going 24/7, right? So if you have a prominence of nocturnal diarrhea, then you're more concerned about infection, inflammation, malignancy in the GI tract that is constantly secreting the fluid. Um, So that's the kind of global approach, I think, associating. So taking a history of so how long has this been going on? What's the sort of extent and the volume, as well as, again, to me, one of the most important historical elements is whether it occurs at night or not. And then the rest of the history, the sort of the background of past medical illness, associated symptoms, medications, is really important because there's sort of a breadth of things that can cause chronic diarrhea. I feel like I missed something significant in the general approach. What was it, Steph?
I sometimes think of malabsorption as a separate category from osmotic. I think pathophysiologically there is an osmotic effect, but in this case, it's not that you're putting in an excessive or different osm, but that there's actually profound malabsorptive. So, secretory, osmotic, malabsorptive, and kind of inflammatory are usually the four buddies that I think of.
It's interesting. So that I think that's what I was missing. Just I knew there was like oftentimes more elements, but my brain filed right like malabsorptive under osmotic, and it filed inflammatory under secretory, which I kind of stand by. But thank you. That's exactly what I was missing. Yeah.
Excited to hear more, Mark.
Yeah, good discussion. So like I mentioned, this started 3 months ago and has never happened before. She's never had any like altered bowel habits in the past. It started about a week after she returned to Mali in West Africa, which I'll get to more about that in the social history. So she was having about 10 episodes per day. At first, like I said, no blood, wasn't related to food intake. She wasn't eating different foods than, say, her family or friends that she was with. It was happening all night as well, and was awakening her from sleep as well. So over the last, the next 3 months, it got maybe a little better where she was up to like 4 or 5 watery bowel movements per day, but she was still having just a lot of diarrhea. In terms of associated symptoms, she lost about 10 to 20 pounds unintentionally over that 3-month period. She said maybe some fevers. She didn't really take her temps, so subjectively. No night sweats that she noticed. She also reported some myalgias as well, kind of just diffusely over this time period. And kind of getting into some of her background data. She didn't have any known past medical history at all. She wasn't on any medications, and she didn't take any new over-the-counters or herbal supplements during this time. In terms of surgeries, no surgical history. For her family history, no history of really malignancies or any GI conditions at all. And like I mentioned, so she was actually born in Mali. She came to the US about 10 years prior to presentation. And she really remained in the United States without any foreign travel up until, the time that I mentioned she went back to Mali. She lived in central Pennsylvania, but also lived in Ohio as well. She previously worked at a warehouse and now cared for her 9-year-old child and her 2-year-old niece. She was sexually active with one male partner for the last 6 years. No pets, wasn't around any animals, and does not smoke or use any drugs.
Great. Thanks, Mark. I'll just add some additional thoughts on the nice framework Zaven gave based on the history. And then Zaven, I'll toss to you the additional backstory of her social history and just exposures in general. So with this great history that Mark got, we're really hearing a lot of pertinent positives and negatives relative to that differential diagnosis of those 4 main categories for chronic diarrhea. The fact that it is happening nocturnally, just as Zaven just taught us, favors that potentially this is not related to her, right? Taking in and eating a big osmotic load, but worrying about inflammatory, malabsorptive, or secretory causes. The weight loss, we often frame weight loss with systemic inflammation, and I think that's a consideration here given the fevers. I will say taking a step back of weight loss, about weight loss and thinking about what it takes to lose weight is important to make sure we don't sort of jump too quickly into the inflammatory category. Specifically being, right, weight loss ultimately requires getting calories and nutrients in, and then it's expenditure. And when we have malabsorptive categories on the possible differential diagnosis for her, I think an important thought to consider is the weight loss actually related to malnutrition resulting from the diarrhea? in addition to considering whether it's actually a sign of the underlying inflammatory disorder, that she's absorbing and getting the calories that she needs to, but her expenditure is higher because of the underlying systemic process. So in this case, I think inadequate calorie kind of intake versus increased expense of it is actually on the table because of both the malabsorptive and the inflammatory categories there. The fevers do kind of favor that inflammatory category also. And then the myalgias, I'll just say I kind of doesn't help me necessarily with the particular cause of the diarrhea, but generally, right, myalgias can happen when someone is systemically sick otherwise. So it does make me wonder about a systemic process, not just a gut-limited condition that's causing this loose, watery output that could also be giving her achy muscles in addition. Zaven, what do you think with adding in the other backstory Mark gave us?
Thanks, Steph. Yeah, I think the travel history is really important, right? Just this woman was living her life, and then she took a trip to Mali, and then 1 week later she developed a problem that has now severely affected her health, right? Diarrhea 10 times a day, losing weight. Wow. So I think it's possible that she developed some travel unrelated condition and it happened to be right after travel, but that would be quite a coincidence. And I think it's appropriate to really focus and frame this as potentially, not just secretory diarrhea or inflammatory diarrhea potentially, but as traveler's diarrhea, which most of the time is actually an acute diarrheal syndrome. And most of the time, traveler's diarrhea is viral, or it's caused by certain bacteria that cause acute colitis, like various forms of toxigenic E. coli, like Salmonella species, like Shigella in some cases, Campylobacter, but those are usually acute syndromes. So the question is, what are causes of traveler's diarrhea that become chronic? And again, if we now think about the inflammatory signs that we've seen, potentially the fevers, the weight loss, point well taken, Steph, that the weight loss could just be from reduced enteric absorption rather than inflammation. But still, so that sort of favored potentially an inflammatory, potentially infectious cause. Now the coincidence or the temporal incidence after travel favors infectious syndromes. So now I'm sort of reframing this as potential infectious causes of diarrhea that are chronic and potentially contracted in Mali. Of course, sort of CDC and learning about endemic pathogens in that part of the world would be part of my practice-based learning, but just kind of off the top, I think of sort of the same categories of any infection. Viruses, unlikely. Bacteria, I do think there are some E. coli species that can cause more chronic phenotypes. I forget if it's like enteroaggregative E. coli or one of those, but it's possible. But parasites become more prominent. Giardia and Amoeba, and then the Cyclospora, Isospora, Cyclosporidium, Microsporidium, that sort of family. Fungal, less likely. So I think that's at the top of my differential now. And obviously we need to kind of look at her to see and have some basic labs to see what the effects of this diarrhea are. If she's tachycardic and hypotensive and is an AKI and hypokalemic, we may have sort of a lot of management to do to prioritize before nailing down the specific diagnosis. But I'm also thinking about just getting stool studies, a PCR culture, as well as specifically trying to test for some of those parasitic pathogens with the appropriate PCR or antibody testing.
Awesome. So the next step will be the physical exam and some basic labs. So examine the patient. The patient's afebrile with a temp at 98.3. a blood pressure of 122/77, a pulse of 85, a respiratory rate of 20, and saturating 100% on room air. So she was actually a little ill appearing, but I would say no acute distress. Cardiac exam didn't appreciate any murmurs. Her lungs were clear. Her abdominal exam was slightly distended, and there was some tenderness, kind of really just diffusely to deep palpation, lower more than upper. Skin exam didn't appreciate any rashes, and she was warm and well perfused. And she was mentating appropriately. For her blood work, I'm just kind of on Epic right now, my EMR. So let me just pull up some basic labs for you. In terms of her BNP, her sodium was 139. Her potassium is 3.2. Chloride 104. Bicarb 27. BUN of 3, and a creatinine of 0.66. Unclear what the baseline creatinine is. For CVC, we have a white count of 26.5, lymphocyte predominant, and I can get an absolute lymphocyte count for you in 1 sec. We got a hemoglobin of 12.9 and platelets of 355. For the liver function tests, we have an ALT of 87, an AST of 47, an ALK phos of 82, total bili of 0.5. We have an HIV that's non-reactive. We have an acute hepatitis panel, which is negative. Coags, PT, and INR and PTT are within normal limits. I do have some stool studies for you. So there is a enteric pathogen panel with in our system kind of just tests for, Campylobacter, Shigella, Salmonella, E. coli. There's kind of common bacterial enteric pathogens, which was negative. A C. diff, which was negative. A stool parasites, ovine parasites, which was negative. We have some stool electrolytes. Just kidding, not for you. And then they were kind of canceled for some reason. And then that's the initial basic labs.
Great, thanks, Mark. I'll kind of talk through the exam and the labs that we have, and then maybe Zaven just ask you the specific question of the negative infectious testing thus far. When we've talked about, given her travel history, infection actually has risen to the top, how much that informs your sort of post-test concern for that category. The physical exam doesn't really move us too far, I don't think, right now. We do know she has some abdominal tenderness, and I would say that might speak to just inflammation, right? Small bowel and large bowel inflammation actually making it thus a little bit uncomfortable for her when we push on her abdomen. I think the other pertinent element of the vitals is they're actually not too bad, right? We're worried about profound hypovolemia, potential for tachycardia, hypotension, not there. She's not having a fever at the moment, but fever is a continuous, right, variable and may not just have caught it. So the fact that she's not febrile right now doesn't mean that these subjective fevers she had aren't present. But overall, an exam that at least reassures us she's not profoundly volume depleted right now. She's not incredibly systemically inflamed at the moment with a high fever and heart rate, but has got some abdominal discomfort, which really does localize with her main symptom of potential kind of enteritis or colitis. The first lab that surprised me was the lymphocytic predominance of that high white count. Generally, the magnitude of the white count is just high. But if I would have guessed sort of what we were dealing with here, I think with some of the bacterial infections that can persist and become more chronic that Zaven mentioned, neutrophilia would have come to mind, would have also come to mind with community-acquired Clostridium difficile. But that's not what we have. We have lymphocytosis. A brief kind of thought about approaching lymphocytosis is the consideration of whether it's reactive to something or primary because of hyperproliferation, which would be surprising in a young woman, but would happen in the sense of a myeloproliferative disorder like CML. But most likely, given what she's been through with a systemic illness, this is going to be a reactive lymphocytosis. How does that help us in our infectious category, meaning what infections are associated with lymphocytosis? Zaven had mentioned before viral etiologies being on the table, or sorry, less likely on the table. And I still think that's unlikely as the primary cause of her diarrheal syndrome, particularly knowing she's HIV negative. I think a brief thought exercise of having viral etiologies of chronic diarrhea in someone who's HIV positive would bring to mind considerations like CMV colitis or just the enteritis that can happen with HIV, but we know that's not the case here. Some chronic parasitic infections can be associated with lymphocytosis. The one that comes to mind to me is toxoplasmosis. Again, we don't have a sense of why she would be a host who would get that. And then tuberculosis, generally, when you sort of sample a part of the body that's affected, often can be a lymphocytic predominance. And so considering her risk for tuberculous enterocolitis is just something to consider now that we've got this lymphocytosis. So the thinking there is probably reactive. It does sort of shift the framework of our potential etiologies of the diarrhea itself a little bit from where it was before. And then just looking at her BMP, some reassuring things also. The hypokalemia with her stool loss isn't surprising. With severe prolonged diarrhea, we typically expect in terms of metabolic parameters a normal anion gap metabolic acidosis, which she does not have. In fact, she has an alkalosis right here that's standing out. We don't know what her net pH is to comment on whether there's a mixed disorder here, but she does not have an anion gap. I think I did the math right, calculating the anion gap is 8. Presuming her albumin is normal, that would be okay, but I'll just make a brief point that knowing her albumin is in profoundly low is important because the anion gap normal range is impacted by the albumin. Your expected anion gap is albumin times 2.5. So did we miss it, Mark? Was hypoalbuminemia a pertinent data point here? Perfect. So albumin being normal, yeah, she's got no anion gap here. She's got a surprising alkalosis for it. So I'm just putting a pin on that now. Don't quite know how that necessarily fits into the etiology right now. And then on her liver panel, we've got a mild elevation of ALT with a normal, or I guess probably upper limit of normal AST for her age. Important to consider now in our framework of this chronic diarrheal syndrome with weight loss, potential fevers, very mild signs of hepatocellular inflammation also, which again, I think might speak to more of a systemic effect of whatever is driving the diarrhea itself. I still think infection is likely here with the exposure history, but that's why I kind of wanted to think in advance of and about like the negative tests. And I assume, Mark, I don't know if this is a single O&P that was negative, but yeah, how does that actually shift our concern for that category? What was your thinking?
Yeah, I think the stool studies so far are partly helpful, but not fully. And certainly for the more like non-typical bacterial, the cause of infectious diarrhea, the less helpful just like a normal stool culture and PCR is, just because it mostly targets those techniques mostly target. So like for both Giardia, as well as the other parasites, and actually helminths too, which I neglected to kind of mention as a category underneath parasites. The O&Ps aren't very specific either. So for a lot of those, I feel like the diagnosis ends up being made through like enteroscopic, like colonoscopic tissue sampling and biopsies, and then histopathology. I forget how exactly like you stain for Giardia, for example, but I think you could do that on like evacuated stool, but certainly for the other parasites, a lot of times the just as normal stool studies are going to be, microscopy is going to be negative. So I think that it's still on a differential. The lymphocytes for me though, Steph, like I don't think I've ever seen reactive lymphocytosis of 20,000. I don't even know if I've seen it of 10,000. So I'm not I've never I don't know if I've ever looked at like case series of like the degree of lymphocytosis and how predictive they are of reactive versus primary causes. Definitely the case overall is very much a set, like the pretest is very much one of reactive lymphocytosis, and maybe this is just a knowledge gap of certain organisms that you get in Mali that can cause profound reactive lymphocytosis and I've just never seen that. But like I think just a magnitude is enough that I would just want to at least run a parallel sort of tracking and a reframing of the case of like, what if actually the travel had nothing to do with this? What if this is actually a primary, some sort of, hematologic lymphoproliferative disorder just with a signature in the gut, which I actually don't think of lymphoid neoplasms of having a prominent signature in the gut and presenting with diarrhea. But so like I guess maybe except for like small bowel lymphoma, which could again be sort of manifest in the periphery with circulating sort of leukemic component as well as cause malabsorption or a secretory diarrhea. So I don't know, the white count just totally threw me. I would want to pursue it. So flow cytometry, and then I think it just kind of ups the ante for me to want to image the abdomen, look for lymph nodes, look for segments of bowel thickening, as well as potentially do an earlier, depending on what the imaging shows, potentially do an earlier sort of endoscopic evaluation and sampling.
Yeah, great point about just the sheer magnitude needing to pursue the kind of primary causes category. Excited to hear more, Mark.
Awesome, learning so much from you guys. So the next, I'll give you a few more labs and some imaging as well. So this patient got a CT abdomen pelvis that showed mild mural thickening and edema involving the ascending colon, suggestive of mild colitis in the given clinical context. And then she also had several prominent mesenteric lymph nodes measuring up to 1.2 to 0.6 centimeters with mild associated mesenteric misting. So some additional labs. She had a TSH which was within normal limits. Celiac screening, which was that was negative. She had an LDH, which was 360. She had an ESR that was 4, a CRP that was non-reactive. She had some workup for her elevated liver enzymes, including an ANA, anti-smooth muscle, anti-mitochondrial, all that were negative. So because of this, during her hospitalization, she continued to have, diarrhea. GI was consulted and they did a colonoscopy. And the main things that the colonoscopy showed is just erythema and inflammation in the terminal ileum, but no masses were detected. And we also got a blood smear as well, which showed some atypical lymphocytes. And the next aliquot will reveal the diagnosis.
Steph, I guess I'll go first and then ask you for help. Okay, I guess the word atypical lymphocyte is highlighted in front of us. So let's talk about that. So atypical lymphocytes are lymphocytes on the blood smear that look not like normal lymphocytes. So normal lymphocytes, and you can't tell B versus T cells on a peripheral smear, they're a little larger than a red cell. They have a rounded nucleus that is pretty dark and takes up probably like 80 to 90% of the cytoplasmic surface area. So it's just like a really dark blue dot with just a rim of cytoplasm around it. Atypical lymphocytes are, I think, a little bit larger and potentially more irregularly shaped, not quite perfectly round. And they have a little bit more cytoplasm. And I forget if they have some intracytoplasmic kind of changes or granules or anything too. But they almost like, I think of them as looking something somewhere between a normal lymphocyte and a monocyte. So monocytes are bigger. They have more of a a bent sometimes nucleus and sort of a larger, light blue kind of cytoplasm. So atypical lymphocytes are most commonly seen in syndromes of infectious mononucleosis, which include acute infections with EBV, with CMV, with HIV, and with toxoplasmosis. But they can also be like neoplastic. They can also just be abnormal. Like I've seen atypical lymphocytes sort of be triggered on an automated diff in the setting of hairy cell leukemia once, as well as like a leukemic lymphoma, like a circulating lymphoma, where again they're not neutrophils, they're not eosinophils, they're red as they look like weird lymphocytes, and again those weird lymphocytes, just like in Steph's kind of approach of lymphocytosis in general, can be reactive to infectious mononucleosis or potentially kind of part of a clonal disorder. So what I would be doing now, what I am going to try to do, actually, well, what I'll ask Steph to do out loud if she can, is I guess just expand the thinking and sort of help us together come sort of enrich or try to recall our illness scripts of like, can any of the causes of infectious atypical lymphocytosis, the mononucleosis syndromes, cause prominent chronic diarrhea, and would they fit with this clinical picture of like, I went to Mali and I came back with this EBV, CMV, HIV, toxo. And then if not, more importantly, I guess if not, yeah, like how do we work up the possibility of a I guess a neoplastic process to account for this syndrome? With the last thing that I didn't address, and again, I'll just sort of leave to you, Steph, is like if the bowel wall sort of segment thickening and then the mesenteric lymphadenopathy favors one category versus the other two.
Yeah, I guess in terms of the illness script for infectious mononucleosis and the question of is diarrhea in it frequently, I will say it is not for me, but this might be an area that we learn quite a bit about in a few minutes. The infectious mononucleosis syndromes that Zaven mentioned that caused by viral etiologies, toxo, et cetera, typically think of like kind of fever, right? Sore throat, and then like inflammation of reticuloendothelial sites. And so that's where like kind of tonsillar inflammation, splenomegaly, some liver inflammation, sometimes with a rash, but primary enteric involvement, I just don't have, and kind of how those systemically present typically. So I think in this particular situation, I think worrying about kind of primary mucosal lymphoma is an important one. We do see that there's lymphadenopathy, mild LDH elevation, and then focal areas of the gut. So I do think kind of mucosal associated lymphoma, it will be an important category that we'll only know histologically really. But then could still on this list, infections cause chronic diarrhea with lymphocytic predominance. Again, the fact you said the sheer magnitude of the white count would be very surprising for something like TB enteritis, but particularly knowing, right, that sort of, I think you said, Mark, like that terminal ilia area did have some abnormalities also, that there's just a tropism there. I don't know the explanation, but I know whenever there's pathology in the ileal area and there's an exposure history for TB, right, it's just so important. That's often sort of a mimic of inflammatory bowel disease. So of the infectious categories that are still there, I do wonder about kind of tuberculous involvement. But when it comes to some of the mononucleosis syndromes, whether toxo or viral, I think this doesn't seem to fit. And I'm wondering a little bit more about the primary kind of gut lymphoma question that was brought up before. I think pathology is going to sort of make the diagnosis for us here. But let's see, terminal. Yeah, I don't know. Other final thoughts, Zaven? I'm not sure. Did I answer kind of the specific questions that you had for me?
I did. You did, but I'm struggling. Because it's been an amazing journey. Like we could just be like, we don't know, and Mark will teach us tons, and it'll be awesome. I am trying to like do the math of like I for some reason I do favor over the some lymphoid or lymphomatous whatever process just in terms of the findings in the blood and in the colon. But the pretest probability of this starting after a trip to Mali is just not letting me, say that as confidently as I would. So now I'm just like torn and I don't know which I would prioritize. I mean, in real life, I think I would pursue both in parallel, and test for both. And again, like the flow cytometry, I think would be extremely high yield and very sensitive if this is lymphoma, just because there's such a high number of circulating cells. So I think I'd test for both, but like what do you think if we were to put our nickel down? What's your breakdown, I guess, like infection versus lymphoma?
I think I'm 70% for lymphomatous process. And otherwise, yeah, for kind of chronic indolent, either mycobacterial, I'm thinking probably mycobacterial or, yeah, very, very less likely kind of fungal in her. We didn't bring up, she has histo exposure also, right? She's in Pennsylvania and Ohio, and histo, whenever you mention TB, of course, should be on there, but has a gut tropism as well and causes lymphadenopathy. Again, not sure why she, as a normal host, would be predisposed for that, but just deserves a mention as a chronic infection that can actually cause predominant kind of gut inflammation.
For sure. Yeah, I'm kind of 70-30 too. I did transiently see at some point Austin bring up HTLV and the fact that like some bells rang in his brain, but that he doesn't know enough about it. I definitely don't either. And that would be a fascinating kind of out of left field. And yeah, Mark, teach us. This is awesome.
Yeah, so you guys are actually both right. The answer is both, and I'll get into why. So the patient had CMV, EBV, toxoserologies, which were negative. Flow cytometry was done on the peripheral blood, which showed two atypical T cell populations, CD3 negative, CD4 positive, CD25 positive, and CD3 positive, CD4 positive, CD25 positive. Then the patient had an HTLV1 antibody, which was positive. And then pathology came back from the colonoscopy consistent with strongyloides. So the patient had a diagnosis of adult T-cell lymphoma leukemia predisposing to strongyloidiasis, leading to chronic diarrhea.
Wow. Very, very interesting. I think I'll just say that beautifully phrased connection that you said, Mark, that the the underlying leukemia predisposed to the infection. I had not sort of thought of that potential link for her, right? That in fact that we've kept calling her, right, because she was HIV negative, immunocompetent host, but that actually underneath there was right proliferative process that gave her relative immunosuppression that thus let her have a diarrhea. So it's just such a cool kind of link of multiple diagnoses, but sort of a bit of a cause and effect almost of why she was at risk for one because of the other. Really cool. Any reflections you have, Zaven, before we learn more?
Just yeah, amazing. I think I have so much to learn. I'm excited to learn more about HTLV, and I remember at some point learning the association of HTLV with T cell leukemia, but I'm also curious what the time course is between like developing the viral infection to developing a lymphoma, and could it happen this quick that where this was is the thought that this was contracted in Mali and then lymphoma developed that quickly, or she's had HTLV for a while. In fact, because she's from Mali, right? So it could have been more chronic. Okay. And then my other reflection is strongy strikes again, man. We see a lot of cases of strongyloides in Houston, believe it or not. We just have like such a diverse population that we take care of here from all over the world. And I've just seen so many different sneaky presentations, and that absolute eosinophil count of 240, like I actually kind of let it go, but it's still to me was like, I don't know, this person seems like they have a lot of cortisol in their body. And And there's actually a study of people from endemic places who have relative eosinophilia, not even above the 450 cutoff, but I forget what it was, between 200 and 400. They have a very high prevalence of parasitic disorders, sort of spearheaded by strongy. So I'm just is one more kind of case in the bank of just always erring on the side of empirically treating and or at least testing for this very, very prominent common, like 1 billion people in the world have it, I think, and it's so easy to treat. So just very low threshold to actually test for it.
Yeah, no, this is thanks. I learned a lot from you guys. It's just a really cool case. And I think it's like really hard to get to this diagnosis before the flow. And like you guys said, we need the flow and then we can kind of move on to the next step. And the thought is that she probably contracted HTLV1 10 years ago when she was in Mali, because that's usually the lag time between contracting HTLV1 and then developing the ATL, adult T-cell lymphoma leukemia. And this is just such a fascinating leukemia. Essentially, it has a tropism for CD4 cells. So essentially, these patients have immune systems very similar to patients with HIV. So there is actually a very high rate of pneumocystis pneumonia, disseminated strongyloides, all infections that we think of in patients with HIV. These patients also get as well, which is fascinating. I want to ask the ID doctors more about, like, do they prophylax against these things like we do in patients with HIV? So I have a lot more to learn about this disease as well. And the other thing I learned too is that actually 20% of patients with strongyloides won't have an eosinophilia. And like you mentioned, this patient might have had like a relative eosinophilia, but it doesn't completely rule out the disease. So yeah, great job. This is such a cool case, and thanks for the great discussion.
Thanks for prepping the case, particularly while you're on ICU and taking time away. This was just really, really phenomenal. And what a great framework to just think about the CD4 particular injury and how that does actually, right, change kind of who the host is in a fashion that's similar to HIV. Bettina, want to take us home with some teaching points?
Yes, definitely. Thank you, Mark, for the amazing case. So I'll just give the main teaching points for today. So our first main teaching point is that acute diarrhea is usually infectious in origin, and meanwhile, chronic diarrhea can be categorized into 4 big buckets, such as inflammatory, secretory, osmotic, and malabsorptive. Important points to take note of in the history would include the volume, temporal pattern, especially occurrence at night, food intake, history of malabsorption, past medical history, medications travel history, history of immunosuppression, and any other signs and symptoms that can point to systemic causes. Our second main learning point is that our patient presented with lymphocytosis, which can be a primary cause, like lymphoproliferative disorders or lymphoid neoplasms with a signature in the gut, versus reactive. So infectious causes of lymphocytosis can include viral illness in HIV-positive patients like CMV colitis, can also be chronic parasitic infections like toxoplasmosis and TB enterocolitis. Flow cytometry, imaging, endoscopic evaluation, and histopathology can be enlightening to differentiate infection versus lymphoma, or even it could be both, which is what happened in our patient. Another teaching point is that patients with relative eosinophilia, around 200 to 400, may have increased risk for parasitic infections like strongy. And then lastly, in our diagnosis, HTLV may have tropism for CD4 cells that can predispose the patient to have like an immune system that's similar to HIV, that increases the risk for PCP and strongyloides. So those are the learning points for today.
That was amazing, Bettina. Thank you so much for summarizing. Thanks everyone for joining.
Thanks again, Mark. Awesome case. Always love seeing you guys. Thanks for the chance to think out loud and learn a lot. Have a great rest of your Wednesday. Bye.